Okay, we are on.
Okay.
All right. Well, hello, everyone. I'm Dan Lepore, and on behalf of the Smith-Kingsmore Syndrome Foundation, welcome to our first installment of our Facebook Live informative talks. During this session, we're going to hear from the absolute expert on Smith-Kingsmore syndrome. We'll dive into characteristics of the syndrome, when it's time for genetic testing, tips to make sure you've got the right doctors involved, and we'll close out with the information on the latest research. The session is being recorded, posted, so you can rewatch it and share. Please put your questions in the comments below as we go along, and we'll do our very best to answer as many as we can. So that being said, it's my honor to introduce Dr. Laurie Smith, the first to describe Smith-Kingsmore syndrome. So welcome, Dr. Smith. Thank you for agreeing to talk with us today.
Hi, it's a pleasure.
So to kick it off, can you tell us a little bit about what Smith-Kingsmore syndrome is and how you discovered it?
Okay, so SKS is really a problem with cell overgrowth, so uncontrolled or poorly controlled cell growth and division. Growth and development, so embryonic development, postnatal development, et cetera, are quite tightly controlled, and they're controlled by regulatory pathways, different regulatory pathways and cascades. And these control that if a cell grows or it dies, and both cell growth and cell death occur normally, okay? In the case of SKS, the pathway that's involved is called the PIK, so the PIK, AKT, mTOR pathway. This pathway controls cell growth and cell death, and the final regulatory protein in that pathway, or molecule in the pathway, is actually mTOR, which stands for mammalian target of rapamycin. If there's too little mTOR activity, things don't develop correctly. If there's too much activity, then there's abnormal cell movement and cell growth. In SKS, there's too much mTOR activity, so mTOR is overactive. There are lots of people who are studying this pathway because it's very important in cancers. If that weren't the case, I'm not sure we'd be as far along as we are, because most studies have actually started because of concerns or interest in cancer. What we know now is that many of the pathways that are involved in the development of cancer are also involved in overgrowth syndromes. So all those genes that I talked about, PIK, AKT, mTOR, those are all involved in overgrowth, and those are also involved in cancer. SKS was actually described because of one patient for whom we performed whole exome sequencing. And it's likely that this would have been identified eventually without whole exome sequencing, but whole exome sequencing actually made finding the gene a lot easier. I was asked to see a little girl to see if she might have what we call an inborn error of metabolism, so problems using sugars or something, and that this might be causing her to have very difficult to control seizures. When I met her, it was clear to me that there was more going on than just seizures. So being trained as a geneticist, geneticists look for things that are different that might give us a clue as to what might be causing symptoms. So in addition to seizures, this little girl had some very unique physical features. So she had very curly hair, a very large head, very short arms, a number of things that just made me think there must be something going on. So at that time, I was working with Dr. Kingsmore, and he was doing a study where we were doing whole exome sequencing on affected or children who had conditions that we thought might be genetic, along with their parents. And so we decided she was a good candidate for whole exome sequencing. And that's how we found that there was a change in the mTOR gene that was present in her, but was not present in her parents. We found this in the blood, which is pretty unusual for overgrowth syndromes. Most overgrowth syndromes are not in the change isn't in every cell in the body. It's in what we call a segment, so the hand or the leg or the foot or whatever. But since it was in her blood, and that's pretty unusual, we decided that we needed to look at other tissue types. So we looked at a couple of other tissue types and found that change in every tissue type that we tested. And that is what made her unique. A variant in mTOR had previously been described in a patient who had what was called isolated hemimegalencephaly. So one side of the brain was bigger and poorly developed, but it was not found in the blood in that patient. So this is actually how it was quote unquote discovered. I think every discovery has a basis in what has been seen before, and I know that there are individuals who had this condition, but were just not diagnosed. That makes sense?
Yeah, that's great. Thank you for that. That was a great overview. What are some common symptoms usually seen in SKS patients?
So, as with any genetic syndrome, when we first describe things, we describe things that are very, very unusual. And then we realize that that's probably the more severe end of the spectrum. So it's a spectrum. So you're not going to see the same things in everybody. But in general, most SKS babies are large when they're born, and their heads are quite large. They can have very tall foreheads, and the soft spot can be really, really big. When you look at them, their eyes can be slanting downwards somewhat, and they have very short noses and kind of small chests. And umbilical hernias are common in babies, but they're also common in babies with SKS. But strikingly, they tend to have short upper limbs and very short hands. They can have low tone and developmental delays as an infant and older, and learning issues. And very unusual findings on brain MRI, where it looks like the cells in the brain haven't moved to where they're supposed to move to when you look at it on MRI. For those, now this is for the individuals who have the variant or the change in every cell type. For those, there are some who have it only in certain cells, so it's called a somatic change, and rather than germline. And in those babies, they can have the large head, the findings that I just talked about, but they may also have cafe au lait birthmarks. So the birthmarks that you can see in tuberous sclerosis, or you can see in other syndromes, and that's because that's a cell has received a signal that it's going to divide more. So those are the main things. But it's funny because that you asked that question, because I actually looked on OMIM today, because I haven't looked for a while, and the findings have greatly expanded since when I first saw the first patient diagnosed with it. So there's a lot more in there. Seizures are often very, very, very common and very difficult to control. So those are the main things.
Oh, that's great. Thanks for that. Now, since SKS shares a lot of traits that are similar with other diseases, when should we be considering the genetic testing to make sure or to identify whether Smith-Kingsmore syndrome is at play here?
So the first thing I would like to say is that parents must advocate for their children, because you're going to go to a doctor and they'll often say, well, I don't know, or well, I don't know how to test. And the other issue is that genetic testing is often not covered. And the only way to truly diagnose it is to actually do genetic testing. But my rule of thumb is if an idea crosses my mind, I ask about it. So if a child comes in with a large head, has poor muscle tone, doesn't gain skills like expected, seems to have autistic-like behaviors, has seizures that are hard to control, doesn't have seizures, but has some of these other things, I would actually push for an overgrowth panel that includes mTOR and other genes in that particular pathway. Now, a lot of the companies have multiple overgrowth panels, and they are, some have all of the genes that I talked about, some don't. So you have to make sure that you ask that it include the PIK-AKT-mTOR pathway. But bottom line is, if it crosses your mind, if a child has autism, if a child has poor development, if a child has a very large head when they're born and they just don't seem to be gaining skills, and they don't have one of the things that that are screened for on newborn screening that can cause large heads, then I would just push for it.
Great. Thanks. So I've heard the term whole exome sequencing. What is that, and how does that help diagnose SKS?
Okay, so whole exome sequencing, and by default whole genome sequencing, is actually a DNA sequencing technique that's now referred to as what we call next generation sequencing. So in the past, when I started in science and genetics and doing research, we were only able to look at one gene at a time. So you had to know what gene you were looking for, and you had to know something where you could line it up so that you could actually sequence it. And that's called Sanger sequencing. Next generation sequencing, or whole exome sequencing, is a technique where you can actually, and whole genome sequencing is a technique where you can enrich for all the sequences in the DNA that code for genes, okay? So those are called coding sequences. And these are across all of the chromosomes. And basically there are regions where you just enrich for that. So you sequence every gene. And that's whole exome sequencing. You're not, with whole genome sequencing, you're actually sequencing the whole genome. So you're sequencing coding and non-coding sequences. But in whole exome, you're actually looking at the coding sequences. So you're looking at specific genes. Now, we would not be able to do this if it weren't for the fact that we now have really good IT and computers. We wouldn't be able to do it. Because what the computer does is it takes those sequences and aligns them. So you can get 50 to 100 or more alignments, and you know that they're in the same gene because they line up. Now, you wouldn't be able to do that if you didn't have a computer. You just wouldn't be able to do it. So because of those alignments, you can also see differences in the sequence. So some differences in the sequence, in the sentence that makes the gene, don't cause a problem. But some typographical errors do cause a problem. And generally speaking, we know what are called variants. We know variants that are benign, don't cause a problem. And we know something that it's easier to pick out things that do cause a problem. So technically, almost all gene sequencing is done by whole exome sequencing today, even when a specific gene or gene panel is ordered. So if you have your DNA taken and they're sequencing one gene at a company, they're actually sequencing your whole genome, your whole exome, but they're only looking at the gene that you're asking about. So if you do a panel for overgrowth, they're only looking at those genes, but they have all the other ones if they need to look at them, but they're kind of hidden because it's personal health information. In the case of SKS, when we did this sequencing, we didn't know what we were looking for. So in that case, what we do is we take parents' DNA and the child's DNA, and we sequence it all and we line it up and we look for differences. So the computer then picks out the changes, and we look at the genes, and you have to make a decision as to whether or not you think it's in a gene that could be in a pathway. So it's a lot of book work too. So you get the DNA sequence from the computer, but you do a lot of book work as well. And in the case of a dominant condition, like what SKS is, the change has to be present in the patient, but it's not present in their parents. So the parents and the patient have to be sequenced, and then the sequences have to be matched up. But again, we probably wouldn't, if you wanted to look at all of the genes involved in overgrowth prior to whole exome sequencing, it would take years because you'd have to be sequencing each gene independently. And now with whole exome sequencing, because you do it all at once, the data's there, you only look at what you want to look at. So it's kind of a hard concept, but basically you're sequencing everything.
Yeah, that's great. So a follow-up question on that is, if sequencing has been done looking for another gene, do these labs hold on to that material? Can you re-request them to look specifically for SKS?
Yes. So the way it works is that that they've, particularly if they've done whole exome sequencing and they know it. The way companies do whole exome sequencing now is they will look at the symptoms that they're looking for, and they'll pick out genes and they'll look for that. But if another gene comes up, you can actually request that they review it and look. So.
Okay, good to know. So sounds a little bit complicated. How do I know I've got the right doctors around me to help treat SKS? Are there specific specialists that I should be looking for to help my child?
Okay, so the first people that you're really going to see is probably going to be your neurologist, especially if a child has a low tone. And the neurologists are getting better about looking at things for genetic conditions, but oftentimes they'll send you to a geneticist. Now, most geneticists will be able to help you diagnose your child. And after that, it kind of depends on whether or not they, how they practice, because a lot of geneticists will see patients, diagnose them, and send them off to physical therapy, occupational therapy, to have their pediatrician or have their regular doctor do that. It's also important to keep in mind, at least here, that insurance will dictate who you can see. But all patients will need to see, all kids who have SKS will need to see a neurologist. They should see a developmental pediatrician. There are some states where developmental pediatricians are rare, and so it's hard to find them, but developmental pediatricians are important. Physical and occupational therapists, ENTs, hearing, for hearing and speech therapists. The bottom line is it's, you're going to be, for each individual thing, the pediatrician or the doctor is going to say, well, I think you need to see this specialist or not. Now, when you actually sleep is a big issue. Sometimes it's hard to find a doctor who's interested in sleep that you can get a child into. And there are very few multidisciplinary clinics that deal with all the aspects of SKS. And I would say that if you're actually looking for multidisciplinary clinics, and I'm not affiliated, I have no conflict of interest here, but Cincinnati Children's Hospital really has done a great job of coordinating a multidisciplinary approach to the treatment of SKS. And so I can put a shout out because I think they've done a great job. There are people at the University of Washington, there are people at UCLA, there are people at UCSD who are very interested in SKS and the treatment of SKS. But I think that Cincinnati Children's has actually surpassed all of them in how organized and they have been as a multidisciplinary clinic. Multidisciplinary clinics, by the way, are difficult to arrange because they're not the model of medicine right now, where it's you make an appointment, you're seen, and you don't spend all day. But with a multidisciplinary clinic, you usually spend all day and you see multiple specialists, so it's a little bit harder to arrange those. But I have no conflict of interest. I'm just putting it out there that I was totally impressed by the people at Cincinnati Children's.
Yeah, we were too. We got the opportunity to meet some of those as well. So thanks for that. So can you tell us a little bit about what's happening with SKS research and where maybe some of that big research is going on? Are there hospitals other than in Cincinnati that might be doing some work, or other centers that we should be aware of?
So there's a lot of basic science research going on with mTOR signaling and overgrowth. And I was looking into this because you asked me about it earlier. And really, as far as basic research, the nice thing about basic research is that the way medicine is going, we're getting more into transitional or translational research. So the basic scientists work with the physicians to basically take what they find and try to get it so that there's a treatment. And David Sabatini at MIT has a real interest in this. He's a basic scientist. He publishes a lot about all aspects of mTOR and in cancer, in overgrowth, and he's the one who first started talking about the ketogenic diet in the treatment of mTOR because of how he knows how that pathway works and that kind of stuff. But supporting basic science is actually how translational interventions are developed. So, for example, the significance of mTOR was really identified because of cancer genetics. Okay, it was also because of overgrowth. So because of that, they know that there are a lot of inhibitors that can be used. And there are some studies that are going on that are not really for mTOR itself, but are for other parts of that pathway where they're using inhibitors to see if that can help. So there's a study called the Mosaic study, which is a multi-institutional study, but really it doesn't work. It's not really involved in mTOR studies. It's more for segmental overgrowth and the PIK-AKT aspect of it, so higher up in the pathway. But what they find will be applicable, I believe, to mTOR. Most of the mTOR studies, like I said, if you go to clinicaltrials.com, most of them are cancer because mTOR is a big player in cancer. So what usually happens first in genetic conditions is you find enough people who are affected so you can figure out the natural history, and then you can figure out the clinical outcomes, and then you can start working on doing specific treatments and you can measure those outcomes. So rather than having it just be one person and having it be anecdotal, you now have a bunch of people together. So like I said, the people in Cincinnati have taken a great lead in this. Dr. Prada, Dr. Kruger. There's a current natural history study through UCLA that's ongoing. It really is, it's not really looking at treatment, it's looking at natural history, but you have to know the natural history of the condition before you can really do treatments logically. Seattle Children's is also doing a long-term study in the genetic causes of developmental disorders. And they are, a couple of people there are really into looking for actual molecules or drugs, whatever you want to call them, that can actually inhibit the pathway and help. Then there are some studies going on overseas as well. So there's some in France, there's some in England. I'm speaking mostly to the American listeners. I'm sorry for that I don't have all the stuff for the people overseas, but it's not, they're every continent, it's on every continent, and so people are interested in studying it. So, and I do think that that's where we're going to get the most information, is we're going to get the most information from the natural history, so we can see what we can do.
Great. Sounds exciting. As the more the better for us.
Like I said, I was reading that, I was on the page and I read the question about wound healing and is wound healing affected? And theoretically, if you have more mTOR activity, you would think that wounds would heal faster. So I'm reading this and I'm thinking, oh, this is a fantastic question, because if you can, now here, of course, this is a scientist talking to me. I'm not going to go around cutting people just to get their cells and immortalizing them and looking. But if you could look in a petri dish and tell the difference between somebody who heals well and somebody who doesn't heal well, who has a variant in mTOR, you might be able to say, oh, this is why this is happening. But it just blows my mind, because it's like you would think that they would heal better, because one of the side effects of sirolimus or rapamycin is poor wound healing. That inhibits mTOR. So you would think that wound healing would be, so it's just, to me, it's just fascinating. And and there are just so many places where you're going to be able to find things where you can help people. And that's the most important thing.
Yeah, it is fascinating. So Dr. Smith, we've got a question from the audience, from Kelly. She wants to know, where do you recommend starting for a child that essentially is no longer a child at 19 and they just got their diagnosis?
Oh, that's a very, very good question. So that's a very, very good question. So where I would start is I would start with the geneticist, because if you start with the geneticist, they're going to know in your area, or they'll have access in your area to people who will be more in tune with working at this. But basically, they're going to be able to say in their note, they might not be able to take care of your child specifically, but they're going to say in the note, they need physical therapy, they need this, they need that, and then they can get that all into place. And that's kind of how you have to start. Now, when you get to be older, I mean, you bring up a very, very salient question, actually, because as soon as you have a concern that your child might not be developing appropriately, if a child reaches age 18 and you don't have guardianship, it's very hard to actually get guardianship. So you need to be thinking about this before your child, sometime around the time the child reaches 15 or 16. But if it's this specific condition, then what you say is, well, and it depends on what the symptoms are, but you say, we know that this is what's going on. We know that, for example, sleep is an issue. We know that you're going to have sleep studies. We know you're going to have to be doing this. And then you contact those people, like at Cincinnati Children's, because geneticists, even though they always call us pediatric geneticists, unless we're cancer geneticists, we see everybody. We see everybody. We see adults, we see children. So, but I think that's the place to start. Does that make sense?
Yeah, I think it definitely makes sense. Great. Well, this has been incredibly informative for me. I'm going to pause just now to see if we have any other questions out in the audience, but I do want to say, first of all, thank you for all this great information, and again, agreeing, to talk with us. It's so rare that you get to actually talk to the person who's discovered your illness. So it's been a treat and an honor. So thank you for that.
Well, it's been an honor to be involved. And I just want to say, like I said in Cincinnati when I went there, the most important people are you and your children. And advocating is the most important thing that you can do. And no, don't take no for an answer. Don't take no for an answer. Okay? You push until you get what you need.
That's good advice all the way around. That's great. Well, thank you so much, Dr. Smith. I don't see any other questions coming in, but I do really appreciate it. And hopefully you have a wonderful night.
Well, thank you for asking me. This was wonderful, and I will keep my eye on the website or on the Facebook page. And people can certainly ask me questions. I might not always have an answer, but they can contact me.
That's great. Thank you.
Okay. Bye.